Hi, everybody. My name is Alexis Mobley, and I am the president of Black and Immuno, an organization that works to amplify, celebrate, and support Black voices in immunology. In case you hadn't heard, we are officially a nonprofit organization, and we are so glad you're here with us to celebrate all of the awesome Black immunologists that we have, our DEI initiatives, our equity work, and as well as going out into the community and figuring out how we can bring our research and our science to other people and other stakeholders. I'm really excited for this week. We have put in so much time, effort, and love into this event, and we are so glad that you are here. So please continue networking. Let us know where you're from, ask questions, have a good time, and be ready for this Black and Immuno kickoff. We have some wonderful sponsors that have helped us throughout this event, including the Immune Deficiency Foundation and Imperial College London. And we'll continue to shout out sponsors and other individuals that have helped us throughout the last couple of years of our inception. If you happen to see people like Susanna or Peju, Irene, Berenice, Joelle, Shayla, they have been pivotal. Oh, as well as our own Coco. They have been very pivotal in making this week successful and making it the hit that it's going to be. So if you see them, tell them thank you, give them a shout out on social media, and just love on all the organizers that have brought this together, as well as all of the other people within Black and Immuno that have volunteered their time and their love and their attention to all of the initiatives that we have going on this week. So with that, I don't want to waste any more time. I know you guys are very excited for our keynote speaker. So I'm going to hand off the mic to Dr. Michael Apata, who is going to introduce our keynote speaker today. Thank you.
Thank you. My name is Michael Opata, and I am at Appalachian State University. I will be the moderator for this session today, and I would like to welcome our keynote speaker, Dr. Faith Osier. Dr. Faith is a professor of malaria immunology, and she is the executive director of the IAVI Human Immunology Laboratory at Imperial College in London. Dr. Osier has deep expertise in malaria, where she believes that we can make malaria history through vaccinations. She previously led two core teams of over 25 scientists across Kenya Medical Research Institute, Wellcome Trust, Kenya, and Heidelberg University Hospital in Germany. Her team's project focused on creating highly effective malaria vaccines through vaccine candidate discovery, identifying immune correlates of protection, and unraveling important mechanisms underlying antibody-dependent protection. They designed an innovative custom protein assay, which was the first of its kind in the African region. She and her team also built a smart network of partners that enabled the assembly of over 10,000 samples from across Africa to probe the new protein kit that they had designed, which was the largest study of its nature. Dr. Osier is the current president of the International Union of Immunological Societies, which comprises over 60,000 members globally, and she's the first African and only second female in that role. So it indicates her expertise and respect in this area. She has also won multiple prestigious prizes, including the Royal Society Pfizer, the Soja, and UKRI MRC DFID African Research Leader Award, among other awards. She's the 2018 TED Fellow and a Fellow of the African Academy of Sciences. She serves on the board and expert committees at the World Health Organization, Wellcome Trust, UKRI, MVI Path, and Bactifac. And she has global footprint as a keynote and motivational speaker. She is the official Together Band ambassador for the UN Sustainable Development Goal 3 and good health and well-being. She's passionate about emerging African scientists as a key agent of change, delivering and health interventions to the continent that is urgently needed. So I will leave the stage to Dr. Faith, and I would like everyone to join me in welcoming our keynote speaker, Dr. Faith Osier. Dr. Faith.
Thank you very much. I'll share my screen. I should have shared it already, but let's share my screen quickly. So thank you so much for the kind introduction. I'm really privileged to be here today. It's such an honor for the Black in Immuno Week to have this keynote lecture. Thank you to the organizers for inviting me. Thank you for all the hard work you've put in. Thank you for everyone who's joined from all around the world. I was very pleased to see quite a lot of people from London, where I am as well. So tuning in from London today, and just want to welcome you all really warmly to this lecture. And so I'll go straight into it, and I hope we have a good time for discussion afterwards. So I want to talk about making malaria history, and that's really the vision of the work that I do and of the teams that I lead. The burden of malaria remains high. Today I'm going to just focus on falciparum malaria, which you can see is all red in Africa, Latin America, India. The burden is still high, and in fact, it hasn't really changed for the last 5 years, despite the fact that we've had bed nets, intermittent residual spraying, fast-acting drugs like artemisinin to treat the infection. We've just not been able to shift the burden despite having all those tools. And it has a big economic impact. In Africa, there are over 200 million cases every year, about 400,000 deaths. Malaria can leave you with severe disability, and for resource-poor countries, disabilities are a major concern. The infrastructure to support this isn't there really, and so it just becomes a vicious cycle, affecting the poor and making them poorer. So it has a huge economic impact, affects economies, it affects families, it affects individual lives in a profound way. And so all the interventions that we have against it, until the one that I'm going to tell you about on the next slide, they all use drugs, and drug resistance is always on the horizon. It's a threat to all the progress that we've made, even in controlling malaria. And so as an immunologist and Black in Immuno, celebrating immunology, I really believe that vaccination is the way forward. And in fact, you've all probably heard in the last few weeks, the WHO has approved and recommended the use of the RTSS malaria vaccine in areas of moderate to high malaria transmission. And so this is really big. You can see in this map the countries in which the rollout of the implementation trials was done: Kenya, Ghana, and Malawi. And based on that, the recommendation is really that this should be in widespread use. And so, in fact, in our lifetime, history has been made on our watch, because this is the first ever malaria vaccine to be licensed. And so you can imagine how thrilled we all are. However, the job's not quite done. With COVID, we know that we've hit vaccine efficacy in the high 90s. Our vaccine efficacy for this vaccine is 30 to 40%. With COVID, we've seen the duration of protection is short. People are already getting booster shots. With this vaccine, again, the duration of protection is low. By the end of a year, the efficacy has dropped even further. And so while we're excited, we know that it's going to save lives. we also know that we're not there yet and that there is more to be done. And that's what I want to talk about today. And so the reason we think we can do more is because humans acquire immunity. So if you live in a malaria endemic area where there's lots of malaria transmission, you see the profile on the left here on the screen, where in green, it's severe malaria. This is life-threatening malaria. You're admitted to intensive care. You see that the burden of this is very high in people under the age of 5. That's what you're seeing on the graph, 10, 20, 30, 40, 50. Most of you are in this range here. Some of us won't declare our age, but for severe malaria, it's really, the burden's really high in the under 5s. We have mild malaria. This is a flu-like illness, COVID-like illness where you have rigors and you're really sick, but you're not admitted to intensive care. If you look at that in the malaria endemic area, a place, I keep on saying a place with lots of malaria because it's variable. Again, you find that the burden's high in early childhood and it goes down as people become young adults. So by the time people are in their 30s and their 40s, they're getting infected, but they're not getting severe malaria. Neither are they getting mild malaria. What they still get is asymptomatic infections, which is denoted here in this pink line and labeled parasite. And this is saying that people are well, they're going about their business. But if you have a look in their blood at any one time, you'll find 30 to 40% are got parasites in them. If you use a very sensitive method, it can even go up to 70, 80%. And so what we observe from such data is that it is possible to become immune. It seems to occur in stages. First, severe malaria, which can kill you, then mild malaria, which is still pretty bad, but we call it mild, and then asymptomatic infection. But what we see is that people get there, and actually the fact that people can become immune and not suffer these clinical consequences gives me as an immunologist and many others a lot of hope that we can in fact make very good vaccines, just modeling on natural immunity. The other bit of data that really lays a foundation of my work was this experiment done in the 60s where gamma globulin, so IgG, taken from people who've had malaria many times. So here I told you could achieve a state of immunity. Now imagine getting a bunch of those people, collecting blood samples, purifying out the IgG, and using that to treat patients that have come to hospital. That's the experiment that was done. And here you see these results from a really nice old paper where when you use gamma globulin from people who've had malaria many times, I saw someone join from the Gambia. This was actually Gambian gamma globulin. What happens is that parasitemia goes down. You can see the trophozoite count there. And I don't show it here, but the clinical symptoms, so something like the fever that you have with malaria, that resolves just by treating with gamma globulin. When you use gamma globulin from people in the UK, for instance, who've never had malaria, you don't have the same effect. And if you take out the antibody from it, again, you don't have that effect. So really, it's antibody that seems to be doing it. And so the fact that you can acquire immunity and you can passively transfer that and observe that it gets rid of malaria gives us a lot of hope that one can make effective vaccines. So Immunology 101 antibodies have an FC part and an FAB part, and they bind to something. And I'm going to focus today on the merozoite stage. That's the whole life cycle of a parasite. I'm going to focus on the merozoite stage. This is the part that gives you the clinical symptoms of malaria. This is also the part that responded to the IgG that was passively transferred in the data that I've just shown you. And so I like to show this little movie just to make it really clear. That's blood cells in your circulation. That's merozoite. That's the parasite stage. It identifies a red cell, it attaches, it orients itself, it invades the red blood cell, and it goes on to make itself at home. It has lots of daughters, and those daughters will emerge. They invade other red cells, and that's how you get the clinical symptoms of malaria. And so looking at this cartoon here, that's the blue merozoite you saw before. The hypothesis is that there are antigens on the surface of this merozoite. That's called a merozoite surface coat. It's got lots of proteins, hundreds, in fact. And the hypothesis is that this is the bit that's exposed to the immune system, and antibodies would be able to see the merozoite and through the FAB bind to specific antigens on the surface coat. There are also antigens here in the apical organelles that are secreted at the time of invasion when the merozoite hits the red cell, as I showed you, and those come out onto the surface, and those could also be targets of protective immunity. And so our research program has been trying to pin down which are the candidates. The RTSS vaccine that's out now, it looks at a different stage of the parasite. It looks at antigens on the sporozoid stage. And in fact, the main antigen there is the circumsporozoid protein, which is in the RTSS vaccine. In my group, we're looking at the merozoite stage, which I've just shown you, and there are hundreds, almost 800 proteins there. And we're trying to work out which of those proteins are the best ones for driving immunity. We look at correlates of protection. We do this through multi-center cohort studies or through human challenge studies, which I'm going to show you data today. And then we want to understand how are antibodies working. When they bind, is that the end of the story, or what else happens to make sure that an infection is dealt with? And so here's a volunteer malaria infection study. And so here, when you sign up for the study, you say, hey, Faith, this sounds exciting. Please, can I join your study? And I say, oh, yes, you'd like to be injected with malaria parasites. Come along, come along. And so that's what's happening here. This volunteer is getting an IV injection of viable sporozoites. We wait while those sporozoites go to the liver. We know that they're going to go there and mature, and eventually they're going to emerge in the blood stage of the infection. And we're on standby to monitor the parasitemia using a sensitive PCR method, and obviously to check and make sure that the volunteers, their clinical condition remains stable. We get ethical permission. We do a lot of work ahead of the study, a lot of informed consent, a lot of stakeholder engagement to get everybody on board before we carry out this infection. And so in this experiment, our volunteers were in a residential facility with things to entertain them, and they had to stay with us for 21 days when the study ended. But to recruit them, we did something clever. So we looked at how much malaria they'd had in the past. So if you've never had any malaria, if you've lived in London all your life, for example, and I look at your antibodies to malaria Schizon extract, I won't find anything or hardly nothing because you've never seen malaria. Your immune response did not need to bother making antibodies against malaria. However, if you lived in Kilifi, where this study was done, and you'd lived there all your life, you'll have had malaria so many times, your immune system will be making whopping antibody responses to malaria antigens. And that's what we see here. So when we recruited our volunteers, we wanted to identify Kenyan adults who had low levels of antibodies, as if they were malaria naive, because it really depends where you live, whether you're getting exposed to malaria or not. So we wanted to capture people with low levels of antibody. We wanted to capture people with high levels of antibody, like our positive controls, and we wanted to get the range of people in between. And this would help us to see, to analyze the contribution of antibodies to protection. So there were young adults, under 50. Most of them were male, partly because they had to stay with us the whole time. I've explained that they had a range of previous exposure to malaria, and we excluded sickle cell trait because that's already known to protect from malaria. So we wanted to see really whether we could just find the effect of antibodies without some other confounding factor. Okay, so in terms of outcomes, this is the most exciting bit of the talk. We saw in a proportion of individuals exponential parasite growth. So remember, I inject you with IV viable sporozoites. They go through the cycle, they come out in your blood, and they grow like mad, like they're supposed to. So we saw exponential parasite growth. We didn't let it go forever. Once it hit a certain threshold, we stopped the infection there and gave treatment, etc. The patients were all safe. Volunteers were all safe. So that was one group. Then we saw another group in whom parasites absolutely did not appear. So again, fancy that. We give you a dose of sporozoites that we know causes people to come down with malaria. And what happened in those volunteers? They just gobbled them up. Nothing happened. We monitored them to the end of the study. We never detected any parasites. And this was just amazing because this is immunology working in front of your very eyes, that we could demonstrate that you can give people parasites IV and the immune system just deals with it, no problem. So that's one of the most exciting things that I've seen in my career, and I'm really pleased about. We had another group of individuals in whom the parasites did appear. So around day 6 onwards, we detected them, but they stayed at a low parasite density and they self-cleared without us needing to give them antimalarials. So again, there was some more immunology, more immunity at work. Yeah, show me those parasites. They managed to break through and come out into the blood, but they self-clear. So that's, again, immunology at work. And finally, we had another group in whom parasites showed up as well, but this time they didn't self-clear. So you can see them lumbering on at a low density, nothing compared to the exponential parasite growth of this first group. So we had now all these outcomes. We had people who were parasites were growing, they tended to have fever. We had all this group in whom we could see some level of immunity, some just controlling the infection, some clearing it, and some just completely smashing it so that it didn't show up at all. And if you want to read more, this is the paper in JCI Insight just come out. And this is how the raw data look. I've just simplified it in that cartoon. And so then we went on to look at the immunology, and we did a bunch of functional assays, growth inhibition, just looking at blocking. We looked at complement fixation, phagocytosis. We looked at neutrophils. We looked at chewing up of red cells that have the parasite in them. And we looked at antibody-dependent cellular cytotoxicity. And we did these because the growth inhibition, we have this malaria assay called the GIA. This is our gold standard assay. Whenever you're looking at a vaccine candidate, you ask, does it block invasion? But we were also interested to see, is it just blocking, or what about these FC-dependent mechanisms? And now I just want to highlight the work of these individuals, given that it's Black History Month. Black in Immuno Week, I beg your pardon. I just wanted to really highlight these Black PhD graduates, so recently graduated. Please note their names down and invite them to speak next week. It's all their work that I'm gonna show you today that did all these functional assays while we were in Germany. And then we had the array kill chip, and we developed this in Kenya. And what you see here is all different proteins from that merozoite stage of the parasite, and they're lighting up, and the intensity is variable depending on the amount of antibody that you see that the samples have. So we're able to use this to again ask, well, in our study, what were the people who were protected What antibodies did they recognize? And here again, I want to acknowledge senior scientists in the group. James Gathoni has moved on to another position, and other African Black scientists that are at different stages of their career. It really takes teamwork to get this kind of work done, right from the time of running the clinical trial, organizing all the lab samples, organizing the experiments, getting everything right. Huge team effort, and I just want to appreciate and show off with all these Black immunologists, actually. So going to some data quickly. Here, what you're seeing is a simple output, IgG to the merozoite, that blue thing that I showed you before. And here I've classified my groups into people who got febrile, who didn't get febrile. These were people who were treated. And here we have people who were parasite positive, the ones that the parasitemia was just rumbling or cleared. And these are the people who are parasite negative, gobbled up their parasites without a blink. And you can see that the antibody, the correlation with antibody levels, those who were febrile and in whom parasites grew, these were the people with the lowest antibody levels, while in contrast, those who gobbled up their parasites and cleared their infections, these were the groups with high antibody levels. Moving on, because we measured lots of different antibodies, I've sort of distilled it into this kind of heat map, comparing those different subgroups that we saw with the strength of the color, showing the strength of the significance of what we saw. And really the most significant differences were looking at the people who were febrile. So if I just go back, looking at this group of people, comparing them to this group and to that group. That's, beg your pardon, that's what gives me these two columns here. And you can see the IgG to the merozoite was predominantly cytophilic. That's IgG1 there, IgG3. We saw a bit of IgGM, certainly not as strong as IgG 1,3, and we saw little of the 9 cytophilic antibodies. This is an antibody to CSP, so this is the antigen that's in the malaria vaccine that's just been licensed. On this side, the changes were not very interesting. Again, here now I'm looking at effector function, all the cartoons I showed you before, neutrophils, complement, phagocytosis, growth inhibition, ADCC, etc. Again, you see strong differences looking at the febrile group versus those who cleared the parasites. Interestingly, the GIA, which is our gold standard, wasn't a big discriminator of people who were protected and those who were not. This is degranulation, this is phagocytosis here. So what we really saw was FC function plays a big role or seems to be strongly correlated with protection. Again, I'm thanking our statistician. He's in the final year of his PhD. Here we're looking at antibodies against the antigens on our chip, which I showed you before. So you don't need to read in too much. These are all many malaria antigens. Those of us who are mad about it, we know them. The rest of the normal world doesn't need to know them. What was of interest to us was their antigens that we've studied for a long time. Those came out really quite strongly associated with protection. There were new ones from our vaccine candidate discovery program that also seem to be associated with protection. This list is organized in ascending order for the best to the worst, and there are over 100 antigens. So you're seeing the best of the best. The ones that are not good, they're cut off the top of the slide because we can't fit them all in. So what we found was a good number of antigens that were significantly associated with protection. And this is just looking at the functional data in the same kind of format. What's really interesting here was that merozoite IgG ELISA, that was the most strongly correlated with protection. You've got complement there, neutrophil there, etc. And like I showed you before, the GIA, our gold standard, was not. And so trying to bring those data together, this is an old analysis now, but it just illustrates what you can do with such data. I'll walk you through just checking my time. So first in the top row here, you have people who are treated. If you're treated, it means you're not immune. If you're not treated, white, that means you're immune. So you can see there's lots more white here, lots more red on the other side. The next line, it looks at the subgroups. So if you're febrile, you're yellow, and you can see lots of yellow here. Whereas if you're purple and blue, there's a lot more here. These are the people who were immune. And then we've looked at our functional antibody data as well as just antibody binding. We picked up the top variables, both from the effector function and from simple binding to the chip. And we've coded that here. Red is strong response and blue is weak. And what you can see is the people who are protected, they're really red out here, much less blue, whereas the ones who are not protected here, there are a few odd mans out, but they're largely red. And you can look at that. So we've taken that. That's what those boxes show. These are the people who are immune. They didn't get a fever, cleared their parasites. These are the people who are not immune, and you have people in the middle. And so there are many ways to split that cake. Here's a principal component analysis where we tried to see whether we could separate the groups. Again, this analysis is a little bit old, but we've been able actually to separate the febrile groups from the PCR negative groups, and that analysis is just getting tidied up. From here, what we could see, this is not treated and treated. There are some people who seem to be in the wrong place. These guys are all not treated. What are these ones doing here? When you drill down and ask, who are you? We found, in fact, that these are people who are immune. They stayed well until like the last day or 3 days to the last day of the experiment, and then they developed a fever. So they get up being classified as not immune, but in fact, they had displayed immunity for almost 2 weeks before it broke down. So again, that showed us that in fact, immunity is not simply a black and white box. There's grades of immunity, and it's not as easy to sort out. Then we looked at the breadth of function. We said, look, we found all these different FC things. They're looking interesting. If you've got one, is it all right? If you have 2, 3, 4, 5, does it get better? And actually what we saw is, yes, it does get better. The more that you can do in terms of breadth, then the more chances were that you were protected. So having 4 or more, is the pink line there, is much better than having none. And you can see that stepwise increase there. We looked at how this correlates with merozoite IgG. And again, we found a nice correlation that you can see there. The more breadth you could do, that correlated well with how well you were binding to the antibody, how well you were binding to the merozoite surface. So we took that a step further and said, right, now we've been looking at responses until here to the whole merozoite. How about we look at it at the antigen-specific level? After all, to make a vaccine, you want to go to a specific recombinant antigen rather than a gunk with hundreds of antigens. And so what you're seeing here is work done by Dennis for the natural killer cell ADCC assay. These are different antigens here, and these are different individuals. And you can see that some antigens we basically converted the merozoite assay into an antigen-specific format. So instead of coating plates with whole antigen, we're coating them with recombinant individual antigens. And when you do that, you can see that some antigens induce NK-ADCC, for example, these ones here on the right, whereas others don't. And so again, that varies a lot antigen by antigen. It also varies. You can see the amount varies within individuals. However, when you look at the number of antigens that people respond to, you can see that this matches well with how much function they can do. And so here, the more that you're able to bind, again, it's similar to the merozoite data, the more function that we can see of the yeah, it's correlated with the function that we can see of the merozoite. And so we really feel from these data that we should consider incorporating antigens that induce FC effector function, at least against the blood stage. That's what we've seen here. I hope you'll agree with me that the Human Challenge Platform's been a wonderful tool to demonstrate immunity in our own hands. I was really happy to show you some new data from Black recent graduates in my lab for those functional assays. Those are under review or in late stages of preparation. We found the merozoite IgG ELISA was our strongest predictor of protection. The breadth of the functional activity was also strongly predictive of protection. And you can take that down to an antigen-specific level and map that back to IgG. And so what we imagine and foresee is that we could identify a subset of antigens that induce a lot of FC activity, and those could be considered for malaria vaccine design. So I want to end there by thanking the huge team that brings together a malaria challenge study. Not everybody is shown here, but I think you'll be pleased to see there's lots of Black immunologists working on the ground. I'd like to thank our volunteers. We got our sporozoites from Scenaria, funding from Wellcome, sponsorship from the University of Oxford, and we worked at the Kemri Wellcome Trust in Kenya together with Pwani University. And these are the people who generated the data from my lab that you've seen. So I just really want to appreciate them. And I want to acknowledge all our funders from the Humboldts to the EDCTP, TIBA, Oxford, and Kemri Wellcome Trust. So thank you very much.
Thank you very much, Dr. Osier, for that great talk. I think the audience will agree with me that it is very interesting to see an expert and a person who is from the African continent doing this great work and working with the local people who are suffering from the disease to drive vaccines in malaria and make malaria history. So with that, we will welcome questions from the audience. And we have some questions that are already in the chat. So I will go ahead and read. So a question from Sarah Solman. She's asking, she says, very exciting data. Did the FC receptor functions detected in the human challenge cohort overlap with the correlates of protection induced by the RTSS vaccine trials?
Yeah, thank you, Sarah. Absolutely, they did. So I have to say this is human challenge. So we didn't do it in the same, obviously we didn't do it in the same people who were in the RTSS study. However, we looked at responses to CSP, the circumsporozoite protein that is included, that is the main antigen in the RTSS study. We found responses to CSP were also correlated with protection, and it's been, we've not been able to tease out which one is the more important. Is it the CSP or is it the blood stage responses that are driving protection, or is it both? So we have a new study now where we're going to eliminate the sporozoite stage and we're going to give IV blood stage infection. And we're really waiting to see, study hasn't started yet, but we're really going to be keen to see whether without the sporozoite stage, we can still see the kind of results that I've shown you today. So watch this space, that data is coming. Thanks.
Thank you very much for that response. And the next question comes from Bernice, and she's asking what type of NK cells was responding. Is there a ligand receptor interaction involved in the reaction?
We're actually just isolating. Thanks for the question. We're actually just isolating natural killer cells, actually from freshly isolated from PBMCs. So people are, we get blood donors and we isolate NK cells just using standard kits. And then we look at CD16 as the marker for NK cells, and that's what we use. I hope I've kind of answered your question. We don't go deeper into the subphenotypes, the different classes of NK cells. We're just using the CD16 markers.
So as we wait for as more people to ask questions, I will try to ask one. So how do you see the contribution of malnutrition in the effort to eradicate malaria using vaccines, since malnutrition affects development of immunity?
Yeah, so in this study, we obviously, because we're going to infect people directly, we find the healthiest people. So when we screen, we actually eliminate, not in a bad way, but for safety reasons, we only include people who meet certain criteria, who don't have any infections, who are in general good health, specifically really because of safety. But whether malaria contributes to malnutrition, undernutrition, this has bothered people for a long time. And I think it undoubtedly does. Yeah.
Thank you. So the next question comes from Essie, and she says that correct her if she's wrong, but she saw that you looked at oxidative burst in neutrophils.
Mm-hmm.
Was that antibody mediated in response to the parasite? And did you look into what reactive oxygen species was important for parasite death?
Yeah, so first of all, for all the FC data that I've shown you, I must have forgotten to say it, those are all antibody dependent. So in each of those assays, we co-incubated the merozoite with plasma from individuals in our study, and then we added in the effector cell type. And then we had controls which had malaria naive sera, so no malaria antibodies. And that's what we use to discriminate where we're seeing antibody-dependent activity versus not. So all of them were. In terms of the exact nitric oxide, reactive oxygen species, I'm afraid I don't know exactly which ones, but that's something I should ask one of my students who would probably be better able to answer you. So maybe email me and I'll put you in touch. Thanks.
Thank you. So the next question comes from Lucy Walker. She's asking, what are the antigen characteristics that determine the breadth of the FC effector function? Can this be predicted?
That's a great question. At this point, I can't tell you. It's quite difficult to analyze. So first of all, we've got to go through all the different antigens to see which ones are inducing which FC function. And then I just gave you a flavor of the variability in responses. So you might not see responses with an antigen in certain individuals, but you see it in others. And so we've not yet got to the point where we're saying, what are those antigen features? What I can tell you at this point is that the most immunogenic antigens are turning out to be the most FC function. So for example, something like merozoite surface protein 1, which is the most abundant protein on the merozoite surface, that's in our hands is inducing a lot of FC function across the board, whereas other antigens don't induce in as many people, and they might be good at NK-ADCC, but they're not good at complement fixation, for example. So there's quite a mishmash to wade through to really say what are the patterns. So that's all I can tell you at this early stage. Yeah.
Thank you. So the next question comes from Francine Becker. She's asking if there are any opportunities for students or trainees to work on this work or similar projects. I want to get more involved in global health.
You're very welcome, Francine. This work actually happens in Kenya. So this is really global health. I'm not sure where you're signing in from, Francine, but perhaps we can chat offline. The next challenge study is going to start, in next year sometime, and this will happen in Kenya. So good opportunity to go to Africa if you're not already there, and get involved in frontline immunology. It's really exciting.
So the next question comes from Devon Edins, and she says, great talk. Did you notice a difference in IGG subclass distribution across your 4 clusters of patients, i.e. those with exponential growth versus low infection versus those resistant to infection?
Yes, I did. And that's really that the people who have a lot of malaria antibody, it's cytophilic, and the people who don't have antibody just don't have it. So it wasn't really like the people who were not protected are making the wrong class of antibody. They were simply just not making antibody. So there's been some literature in the past that, the ratio of your cytophilic to non-cytophilic antibodies, etc., is important. And that may well be true. But what we saw in this study was that people who make antimalarial antibodies, they mostly make IgG1 and IgG3. And that's also what we know from, all the years that we've studied seroepidemiology of malaria. And we find little IgG2 and little IgG4, and that was the same. But the important thing is that it told us, think about function, because those cytophilic antibodies, they mediate function through the effector cells, like I've shown you. So that's what we found, rather than non-cytophilic antibodies. Yeah.
Okay. Yeah, I think some of the answers you have given touches on this a little bit, but Antonia is asking what immune cell phenotypes stand out between those who clear the parasite completely compared to those with milder clearers, and those who were unable to clear the parasite without intervention.
Yeah, great question, which we've tried hard to dissect. Quite frankly, those groups, I showed you 3 groups: people who were clearing, people who were completely negative, and people who had low levels of infection going on. Actually, it's very difficult to distinguish those 3 groups by the measures that we've had. We get an idea that the people who were parasite negative had the strongest immunity from general analysis, but they are very, very close to those who are self-clearing and those who are controlling. So I don't really feel that we've completely separated those 2 groups, frankly. Immunologically, they look really similar in terms of what they're doing by the measurements that we've got so far.
So the next question comes from Black in Immuno, one of the organizers. They would like to know if there was any difference in the generation of malaria clearance between males and females.
No, I'm afraid not. We didn't find any differences by sex.
So the next question comes from Yasin El Faki, and the question is, the question could be out of the scope of your expertise, but they want to know if there was cross-reactivities with other Plasmodium species.
So we've not tested that yet. We've not really tested that yet. We focused on falciparum because that's what we were chasing down. It's not to say that it's not an important question, but where we are, falciparum is responsible for over 95% of the infections, and the others are really, the frequency is quite low. So most of our work here is targeted on falciparum. With colleagues in Thailand, we're doing similar type of experiments on Plasmodium vivax, but that's a story for another day. For here, we've just focused on Plasmodium falciparum.
Thank you. So there are a lot of questions and interest, and we will probably take 1 or 2 based on the time, because we would like to go into the networking section in a few minutes. So we will take questions until 1:55, 2 minutes, and then we go into the next session. So the next question comes from Bernice again. It's asking, is there antibodies involved in ADCP and ADCC structures work going on?
Sorry, I haven't quite got the question. Is there
antibodies involved in ADCP and ADCC structures work going on? I think it is missing something, but I think it's talking about antibody-dependent cytotoxicity.
Yes, yes.
But we can.
Yeah, so it's phagocytosis and cellular cytotoxicity that you're asking about, but I'm not really sure what about those that you want to know, Bernadine.
Yeah. So we'll take one more question, and then we will go to the next stage. What importance of ADCI in your study? And the question comes from Salem. And also, if ADCI allows to get more response compared to ADCC in malaria.
So the antibody-dependent cellular inhibition assay, we didn't do that one because that assay is notorious, has been around for a long time, but only really working in a handful of labs. It's been very difficult to reproduce. So we rather established our own assays using whole merozoites, and we looked at, we opted to go for natural killer cells and the other assays that I've shown you. But the ADCI assay that's been around for a while, that's been quite hard to reproduce, and I'd be interested if you've made it work, because a lot of people have tried and it's a tough one. So we've not done that.
Thank you very much. There are several questions, and I think we are running out of time, but there is a networking section that we are going into, and you can get a chance to talk to Dr. Osier. So I would like everyone to join me in thanking again our speaker today for that awesome talk. And then now I will pass over to Joel so that he can give us information on the next session. Thank you very much.
Hi, everyone. I want to thank again Professor Osier for giving us a fantastic keynote lecture and really set the tone about what Black in Immuno Week is about. And before to tell you more about the rest of our programming, I'll just take 1 minute to encourage the Black immunologists in the audience to take part in the roll call today on Twitter and other social media. And I am sharing my screen with a set of tweets that we had last year for Black in Immuno Week 2020 to really show how you can really get some exposure out of sharing about your research, sharing about things that you enjoy in life, what's beyond science for you. All of this is a really good opportunity to really take on some space and really show what Black in Immuno is about. The next thing that I want to say is that, so we are going to a networking session, and you have two options. There is an option where you can basically have a fast pairing with different members of this community that are on the platform, and that includes other Black immunologists, other scientists that are present as well, and some of the Black Immuno organizers. And the second option that you have is to join a session where I'll be talking about Black in Immuno, the organization, the work that we're doing. And in particular, I'll talk about the Black Immuno Hub. And I'm sharing here my screen. And this is really the next big work that we're preparing, really trying to bring together elements that will contribute to career development of Black immunologists, but also a set of tools that will gather the community. So I'll be in a room talking about that, and there will be also the session where you can have some one-on-ones for 5 minutes with different members in a random fashion, which can be very fun. To start a conversation, you can, for example, start with what's your favorite immune cell, which can either start a fight or actually create a friendship for life. You can also discuss about what Black Immuno and the community here is, the meaning of Black Immuno for you, and how this is, something that has brought something for you, or any other subject that you want to talk about, your research. You can ask the person about their experience navigating academia or industry, if they're in industry. Basically, everything is allowed. You have 5 minutes, but you can stay in the room a little bit longer if you feel like there is more to discuss. All right, that's it. I'm welcoming you all again, and Black Immuno Week is going to go on all week, and we're really excited to have you. Thank you very much.